my advice would be thinking about evidence right from the start. The landscape has changed, that every single person that is going to be involved in your journeys, any of those people, whoever you're working with, are going to ask you for that evidence. Cash is king, but also cash is strapped everywhere. So you need to be able to demonstrate economic evidence for your solution as well. Where is the value for money for anything that you're creating? And is it any better than the incumbent? So yes, it might be bright, new, shiny, amazing, but actually, is it better than the kind of day-to-day?
Saira Ghafur, welcome to Healthtech Podcast. How are you?
Thank you. Very well. Slightly cold, but good.
Slightly cold, yes. Scottish accent. You in Scotland?
No, in London.
Fine. Well, great to have you on. There's loads of reasons to have you on. So, I mean, I'm sort of taking my pick here. You've done medicine and involved in tech on the ground floor. You've become a consultant. You've got a few different co-founder titles in various different things. SIMA, which is mental health technologies, Prova, Dean Street Advisors. So you've got all of that. You've got an academic role with Imperial. You've written reports on cybersecurity. So there's so much we can talk about in your background and health tech. So yeah, really excited to have you on. First question then, I guess, tell us your story. So where does it start? I mean, you got all the way to consultant, which is interesting. There's so many people leave and want to leave and don't think that, medicine at the consultant level is conducive with health tech, and people trying to get pulled out before that. But you obviously made it all the way through. So congrats, first of all. And again, I always say this, like, I'm always intimidated by an actual consultant because I've still got that part of me that that never quite made it as a medic. So yeah, well done. And I'm a bit scared of you still, but yeah, tell me about the medical journey. Tell me about all the way to consultancy and all the stuff you're doing in health tech.
So I trained in Scotland, actually, medical school wise, and then very quickly left. Never actually practiced in Scotland, and have worked pretty much everywhere in England. I would say from junction 25 of the M1 up to junction, I think 40 something. Lots of various places.
Nottingham 25.
No, actually, no, junction 21, Northampton.
Oh, okay.
All the way up to Pinderfields and Pontefract.
That's a fair distance that you've covered.
I've got around, yes. So it's quite good fun. Not sure why I chose respiratory, but kind of went around the houses, went through what I didn't like, and then eventually did pick respiratory and stuck to it through many years, and went through the whole med-reg drama, which was character building more than anything. I don't actually know. I think it is probably the worst job on the planet. So
I think it probably is. Yeah, I was actually going to try and be diplomatic then, but no, I mean, there's no point us being diplomatic, is there? Like, it's only us two here. Sorry, we can be honest.
Yeah. I mean, forget SES training or anything. I mean,
it's quite funny actually. Someone said to me once, if you're like, I was listening to a conversation about someone was explaining what they did, and they said, it's just such a really exciting job, and someone said if it was that exciting, someone would have made a TV show about it. And it's funny, like, you talk about the SAS, or there's loads of TV shows on police dramas and this, that, and the other. There are plenty of TV shows on how dramatic it is to be basically a med-reg. The amount of hospital dramas that exist, it's because, yes, whilst it might be interesting for the viewer, in real life, one has to live through that. Like, it is quite stressful.
Remember the most ridiculous bleep I got was, there's a pigeon in this patient's room. Can you come up? I won't swear, but I was like, my response down the phone was not very diplomatic.
It's amazing, isn't it? That if
skill set you develop.
If you're listening and trying to piece together the context of what a med-reg is, it's basically being bleeped. It's open season to be bleeped about any problem in the hospital of any severity affecting any patient in any clinical department or area. You are literally at risk of being bleeped, to the point of, if a pigeon in someone's room, someone has gone bleep the med-reg.
Yeah, exactly. They'll know what to do.
Yeah, yeah, yeah. They'll know exactly. They'll know. Which again is the positive side of it. The assumed level of competence, and actually, genuinely, the level of competence that you have. You are. There's a point at which, as the med reg, you are just top of your game. Like you've just sat paces and passed it. You're so experienced. You know absolutely everything. Like there's probably not a shred of anxiety as you walk into the hospital because you kind of know that
Yeah.
you can actually solve everything. I'm speaking as if that was ever me. Like I was so far from that, like unbelievably far from
Oh,
that. Oh
but
dear.
it's quite fun. It's quite fun. Maybe like looking back through rose tinted spectacles, it was
Perhaps.
there were
Yeah,
good
perhaps.
times.
Were you
There were
involved in
definitely
tech as a junior and as a med reg? Were you into tech at that point?
100% not.
Interesting.
Like literally, it was not. I mean, not something that crossed my mind. So it was always kind of, what else can I do?
Yeah.
Because they'd always saying, perhaps. I mean, going back even further before university, I come from an Asian background, so it was basically be a doctor, find yourself new parents was the kind of
Exactly. Yeah.
vibe.
We'll love you once you get through
Yeah,
medical
yeah.
school. Yeah. Yeah. Yeah,
I'm
yeah.
a
Been
doctor,
there.
so I think I
Yeah.
wanted to. I mean, what was it as a kid? I wanted to be a businesswoman.
Yeah. Yeah. I
Anyone
want you to
ever?
be busy and have meetings. Yeah.
Yeah, yeah. I wanted to be a businesswoman, and that was like quickly beaten out. It's like be a doctor. So I did that, um, and then yeah, never really thought about it, but always knew I wanted to do something else as well as the
Mm,
medicine. So I was going to, at one point in time, I was going to do a PhD in pulmonary hypertension.
okay.
And then that quickly, when I realized I'd have to sit in a room by myself for about 3 years, that was less appealing.
I was going to
Um,
say not as glamorous as it sounds. It's arguable how glamorous it even sounds, to be honest. But
yeah,
would
I
have been
say,
great once you'd got it.
yeah, but maybe not the path to it. And then I was always very interested in politics and policy. And
Oh,
but at that point,
nice.
I didn't actually realize what policy was,
Yeah,
in that whole kind of, what is health policy.
yeah,
So then did a couple of fellowships. So one I did, I was doing my respiratory training in Sheffield.
yeah.
And they have quite an extensive kind of out of program experience offering. And one of them was it was our fellowship in quality improvement. At that point, was the kind of thing that was the thing to do. So did that for a year, and actually that was brilliant. Just more than anything, to have a bit of time out from training, because it is quite relentless. You're doing one exam, you do the next one, and you're moving here, you're moving there, and it's like absolutely constant and
I
non-stop.
hear
So,
this from everyone, by the way. Like the amount of people I talk to on here that have
mm,
ended up in health tech, the defining moment so often is
yep,
I got some time. It's
yep,
so often I did a fellowship. I was broadly 9 to 5, had my
yep,
evenings, had my weekends, and with that time,
yep.
managed to plot this, that, and the other and divert my attention to what I was interested in and a bit more autonomy to do that. And it's funny, isn't it, that the blinkers are on through training and
Yeah.
you are just robbed of that
Oh, it's
time to the time to think about other things and to actually do like a deep solve on your life or your career. That you can do these superficial solves of like, oh, I'll get a cleaner and that'll solve this hour and I'll do that and this. You can do that, but you can't actually go, am I on the right path to
exactly what am I
what is
doing?
actually going to tick my boxes here and give me a decent life in career? Yeah, it's yeah. Because I had the same thing when I did the fellowship. Because we did the same fellowship, didn't we? The National Medical Directors one. Yeah. So yeah, I had it on there. Just worked at HEE, got my relative 9 to 5, and then all of a sudden it was like, oh, I could do this. But you got time to research it as well and actually look stuff up.
It was amazing, honestly, and then I worked with, like, brilliant people there, so, it was actually really fun, really interesting, but more than anything, people who push you to think about what you're doing, and it's, being forced to kind of get outside your comfort zone and
Yeah,
why
because
are
you
you?
were at NHS England, right?
No, so this point, this was still in Sheffield.
Oh,
This
got you, got
was
you, got you.
the first of 3 fellowships I
Oh,
did.
nice.
So this was quite fun. So did a lot of quality improvement work, and then also started a health policy masters at Imperial, which was brilliant. Spent I think about 8 weeks in Switzerland doing another fellowship within a fellowship, which was a lot of fun. So
What
traveled
was in
around
Switzerland? So
Switzerland.
why Switzerland? What was there?
Well, they had it was this, it was called the Hope Fellowship, so it was,
Okay.
quality improvement in hospitals, um, and you had to pass a language test and obviously slightly, embellished
French or
with,
German?
well, French, English, and German, so
French,
obviously,
English, and
well,
German. Wow. Okay.
passed my English test with flying colours. They
Yeah.
said,
Perfect.
my French was slightly rusty, but that was good,
Wow.
and German, I, taught myself to speak German for
Good for
this
you.
test, and, they said
Incredible.
my German was terrible, but, I could maybe try and speak English and French instead.
Good for you, though. That's awesome.
Um, but as, everyone knows, Europeans are amazing at speaking languages and speak excellent English, whereas,
Mm,
Brits are terrible
mm,
generally.
quite.
Um,
Whenever I get to
that's
France,
quite fun.
I always speak French or try to, and they always respond in English. But they respect me for trying,
Yeah,
which I actually think
exactly.
my French is all right as well. And it's just not really disheartening when they just reply in
Yeah, you
English.
go
But
there and you're like, "Nah, actually,
yeah,
let's just speak
yeah, like
English."
no, give me the practice, man. Like I want to. Oh,
And yeah,
anyway.
so, ich spreche nicht Deutsch. So
Wow.
that's
Well,
that was generally my response to most things.
yeah.
But yes,
My
that was the
Deu-
first
my Deu- my
fellowship.
Deutsch is Scheiße, so I
Yeah.
won't worry about it. Um,
So yeah, finished that fellowship, went back into training, and then applied for next fellowship, which was a national medical director's one.
nice.
And then ended up working at NHS England with Bruce Keogh. And during that time, it was really interesting. They were starting the new care models program. So ended up joining that program with Sam Jones. And at that point, Tony Young was the national director for innovation,
Mm.
and that's when the kind of interest started to see what was going on
Ah.
in terms of tech and innovation and how you can bring it into healthcare.
Just out of
Yeah,
interest, what was the new models of care thing? Because when I did it, there was a few people at NHS England, and they kept talking about this, and I probably knew it at the time. But what were you actually doing at NHS England? Were you working with Bruce Keogh himself?
so I initially started working with Bruce, and then Sam Jones had started the new care models team, and I was like, "Oh, this is quite interesting. This is a new thing going on at
Ah,
NHS England."
yeah.
And asked Bruce if I could switch over
Oh,
to
cool.
Sam's team, and then ended up leading some of the workforce planning for what these new care models would look like, and work with the rest of the team there. So it was again another excellent experience in terms of actually policy making, policy decisions. How do you actually get this done? Writing reports for the chain upwards. Who do you need to work with collectively to kind of get something across the
Yeah,
line? So actually, it was a brilliant experience, but just working with a huge different number of like stakeholders, which
yeah,
again you would never really get the opportunity to do.
yeah.
So it's actually a really good couple of months. And then uh,
Just before you move on, because I remember doing that fellowship, and I really I gained a big respect for policy actually, because I think, especially in my world and my kind of personality of just wanting to remove all context and assume something's easy, and you know that sort of the youthful naivety of why don't you just do this, like actually spending a lot of time in policy gave me much more of a respect for like what policy actually is, what changing policy actually
yeah.
entails, but then the very deep and meaningful changes that can come downstream of a good policy change is far beyond what any quick individual can do with a quick quality improvement project or that kind of thing. And that's broadly what I learned from it. But like, what did you get from it working in policy?
I think it's, as you say, 100% all of those things, but it's in appreciating the different layers involved in policy
Yeah.
making. So it's not just a case of here, I've got a brilliant idea, I'm going to write a paper about it, which often love doing at Imperial's Ivory Towers. But it's how do you actually influence change, and actually most of it is all behavioural change, isn't it? So if you're writing something that isn't going to resonate with the person who's actually going to make the change, then it's never going to be enacted. And how do you influence all the layers of bureaucracy or people management, every single thing? Is it actually what you're consequences of changing that policy, but what are also the unintended consequences? How are you going to pay for it? What's the kind of push, the driver? How are you going to maintain something? So it's all of those different things, which, I mean, going from I've got this great idea to actually now I've got to figure out all of these different questions, but taking people along with you. And it is all very much, I think it's
I love that. I absolutely love it, because one thing you said there about it's actually behavior change and actually just getting the change to happen. It's where I first started getting interested in politics and media, and like how, like why, like, because you trace policy upwards and you'll get to politics, because ultimately, you know, NHS England, the arm's length bodies, you know, we're all answering to ministers eventually when we're in there. So yeah, we're responding to, at the time, the Conservative government, now the Labour government. But you're right, how something is received, how that policy is received, is as if not more important, and actually therefore the relationship that they have with the media and leaking things and how things get broken and why the metrics are how they are. I can remember at NHS England just being in some meetings where it was all about the GP numbers when I was there. So when I was at HE, it was all about the numbers of GPs. That was the metric that everyone was hanging their hats on. And I can remember just some of those meetings just having whatever numbers were said in a couple of, you know, meeting rooms in HE ended up getting like quoted at Prime Minister's questions.
Yeah,
And you're
it's
like,
amazing,
it's
isn't it?
interesting, because I've seen how that number was created, and I'm not entirely
Yeah,
convinced that it's the
right.
same way that the inflection was used in the sentence. It's quite interesting.
Oh
Am I
god, yeah.
learning about spin at this point?
Yeah,
But it was super connected, like super,
yeah.
super, super connected, because it was all about how that lands. And you're right, how that influences votes and how that influences democracy and all the rest of it. It was, yeah, there's parts of it that I found super, super interesting.
So what happened to your career as a spin doctor then?
Well, it's coming. It's
Yeah,
coming.
yeah.
Yeah, I mean,
Next step.
it's interesting. So politics remains interesting to me. I don't know if it's, I mean, I don't know if it's ever going to be available to me, first of all. Like, I don't know if I'm ever going to have the level of success or notoriety required to even start entering that world. But it is
I mean, Liz
still,
Truss was prime minister, just
it's a
always
very good point. So on the
yeah.
basis that it is available to me, um, I remain interested by it. I remain interested by the fact that it's messy. Like exactly what we've just talked about now. It's about how things are received. It's about relationships with media. It's about relationships with colleagues. It's about getting things done. I like that. Like I was going to say I like that game. I think it is there's a, I don't mean like I would treat it as a game that's unimportant. I mean that like there's a game to play in order to balance those things to get things done. And there's like a Machiavellian nature to that I kind of like, almost, that I could definitely see
But the point is
myself.
actually it's people, relationships, and behavior,
Yeah.
all of that. And
Yeah.
actually, if you're not good at influencing those things, then
Mm,
um, it's a difficult place to
mm.
be.
Yeah. Like slow moving corporate politics, I don't like, but flip that into a high stakes, fast moving, like then it starts to become, yeah. I don't know. There's a political comedy called The Thick of It. Very old
Yeah,
now,
yeah,
but I don't know if you've ever seen The Thick of It. But if it's like that, I'm in. Like, you
yeah,
give
yeah.
me like a Malcolm Tucker character to mess around with. Like, yeah, cool, I'm in. But
Right, so anybody listening to it who's an MP, James is out there.
yeah, I'm interested. I'm interested. I'm
Yeah,
interested. I'll explore it. I'll
excellent. Look
explore it. And
forward to
again,
meeting you out there then.
well, as I say, that suggests that I'd have any sort of skill required, which is probably a far leap at this point, given people dedicate their
Well,
careers
you'd
to
be
it. So I
far
don't
too
want
British about this. If you're in the US, it'd be like,
to. It's playing out in real time, all of this, isn't it? Oh god. Yeah, in the US it's crazy, isn't it? I mean, they had Reagan, they've got Trump, they've got, I mean, now it's just, if you've got any sort of level of celebrity, Schwarzenegger, like you've got any sort of level of celebrity, you're sort of like, do you want to sort of govern a state? Do you want to sort of do
you've
yeah.
got your own podcast,
I've
so
got my own podcast.
that's
Yeah.
wait,
The next
you
logical step is to run for office. Yeah, absolutely.
excellent.
Although, you know, health secretary, I mean, would I be a credible? Anyway, let's not go down this route. Let's talk about you. Um, Fellowships. You did some fellowships, and then what?
So it went back 11 months back into medical training to get my CCT, and I think that was probably the longest, hardest stretch
It's
was
going to be
that
hard. It's
last
going to be
11 months.
hard to go back to
Um,
clinical and
yeah,
be spoken to
eh,
by a TPD.
yeah,
Um,
oh yeah, and then kept getting asked what I was going to do when I CCT'd and when was I going to get a proper job. Um,
the belittling is like never ending in medicine,
yeah,
isn't it?
I was like, nobody's going to take you seriously if you do this silly
Oh, of
tech stuff.
course.
Yeah,
Yeah, of course.
um,
If you do this, what?
silly tech stuff,
Silly tech stuff.
and
There it is.
get real. And yeah, nobody really quite understood what yeah, well, and the health policy stuff, it was like, yeah, that's
Mm.
fine, but,
Ah, of
you can
course.
you can write an audit another time. And I was like, "That's not what health policy is."
Wow.
But yeah,
Wow.
it wasn't particularly taken seriously. So, and at that point, I was like, "Maybe I'll apply for another fellowship."
Okay.
So then I applied to do a Hartness fellowship,
Oh,
that was a
that's a proper fellowship.
proper policy fellowship, which
Mm.
was brilliant. So that was so then I applied, got it, and then ended up when I did CCT. So I did make it to CCT, which was great. And then went to and then as before I CCT'd, acted up as consultant for 6 months, which was quite fun. And then I remember getting a bollocking off the medical director on my last on call and then responded as to this is why I did it. And they were like, oh, that's actually a really good point. And do you want to join this committee? I was like, no, because I'm flying to New York next week and I'm out of here. Goodbye, NHS. So that
Oh,
was a
wow.
nice way to leave. Uh,
Yeah. Okay.
and then went to New York to do a fellowship in health tech,
Yeah.
and policy, which was amazing.
Wow.
That was a really actually, I think that was probably, like, the pivotal year, I would say,
Okay. Why?
in terms of, changing career direction.
Right.
Again, it was when you kind of, like, go back into clinical, the noise kinda starts again, and you're like,
Mm.
"Oh, what am I gonna do now?" And job-wise and everything else, but actually, more than anything, it was a complete, you know, escape from kind of NHS, clinical, what's
Mm.
next, and a proper break from all of that, but also what's next and what I do. And just super interesting in a very different context, environment,
Mm.
learning about a new health system, a different way to see how things are done. Because the
Mm.
thing, one of the amazing things of working in the NHS is, a system very, very well.
Mm.
And doing all of that, all of the different policy fellowships, getting to know the kind of system as a whole.
Mm.
Then going to explore somewhere completely different where you're the newcomer, you don't know anything about it, asking the stupid questions,
Mm.
learning new things, meeting new people. It was absolutely amazing. And then again, so my project for the year was kind of looking at health tech, consumer facing health tech, and learning
Okay.
from different industries. So this was about 9 years ago, and how that
Phew.
landscape changed is
Wow.
amazing. And actually, I'm in Boston next week. I'm going to meet one of my mentors, who suggested that we write a follow-up paper from what we did at the start, where
Wow.
it was all like fairly kind of nascent, all of the kind of consumer-facing stuff, and now
Yeah.
literally we've got ChatGPT and OpenAI,
Yeah.
um, and I think
Unrecognizable.
like all of these things, basically they are your health tech advisor, on
Wow.
hand. So how things have changed. Um,
Yeah.
mm,
Crazy. And closing the loop though to respect your audit origins. Ideal. Ideal. Um, one thing I do just want to point out though is that you are still clinical. Do you still work in, is it an NHS clinic that you still do?
yeah, yeah. So came back when
Yeah.
I finished the Hartness Fellowship. Came back to the UK, and then applied for a job to work at the Institute of Global Health Innovation at Imperial,
Yeah.
and lead our health tech policy unit. And still work there with Aradarzi.
Oh, nice.
And at that point, affiliated with St Mary's and ended up doing clinics there. So an
Yeah.
honorary consultant at St Mary's. And then when COVID happened, I did actually go back in as an inpatient consultant as well, which was
Wow.
interesting to say the least
I bet.
after a couple of years out. But no, still practice, do clinics, respiratory clinics, and then we also look after the Grenfell population as well. So do that once a month. So it's yeah, it's brilliant. Actually, I'm very, very lucky to be able to still do that clinical because I do still love it. Love it. An incredible team.
Yeah.
The respiratory team there are
Yeah.
brilliant, super helpful, and just very good colleagues. So it's great to still be able to do it. And I think it just does keep it real.
Yeah.
Um, I mean, you can write health tech policy, you can do
100%.
health tech, but actually, when you walk into a clinic and no bloody clinic room in the NHS is fully functioning Wi-Fi, and somebody is trying to show you their results on their NHS app, and we can't get onto it, it's really basic things like that where actually you're kind of like, we're trying to bring like the latest AI
Yeah.
technology to the NHS, but literally we
Yeah.
can't get the basics right. So
Yeah, you're right. It keeps it running. It keeps you humbled by what the problems on the ground floor actually are. I think the other thing as well is that I think fairly sometimes like I can get criticized for glorifying leaving, and like we've done a bit of NHS bashing here. The NHS isn't just one organization. It's 100,000 different organizations, and everyone's got their own problems. And as any big corporate employer will have, they'll have slow moving stuff. They'll have people that try and beat you down in terms of promotions. Or it's just another employer that obviously has its issues as well. And I think it is worth pointing out though that things do change when you're a consultant in terms of your time, in terms of your sway, in terms of your ability to have impact on the way that things are done in the NHS. And actually, even your optionality within health tech will, I imagine, look very different as a consultant as it would do in other places. And so I don't think it is about glorifying leaving. I don't think leaving's a good idea for people for which it isn't a good idea. I think for some people it definitely is for everything that they want to do individually and what they think they can do in the system. But obviously for you it wasn't. It was more important for you to stay. So can you talk me through that decision? Because I imagine, you know, although you just come back from the Heartless, you've got 11 months still to do or whatever. Like I get that seems like a short amount of time. I also know people that have gone at STA and not CCT'd, and so you mentioned it was the hardest bit to do, and so I imagine many people do still leave at that point. What do you think the advantages are of getting to consultant for your options within health tech and for everything that you've done, and like what does that decision mean to you personally to stay until consultancy and still practice?
so I mean, I would say one of the I mean, just going back earlier, it was always what else can I do alongside? I could never
Interesting.
envisage myself
So
doing
that
it
was
full.
always your frame.
Yeah, but it was kind
Yeah.
of, I still loved the job
Okay.
and, it's such an incredible thing that you've been training for, and it's not even training through medical school and everything else beyond. It is, all the way through your schooling to,
Mm.
get your A levels or higher or
Yeah.
whatever else to be able to get to medical schools, all of that. But actually just as a job, it is incredibly rewarding and it's an amazing thing to do and did always the good bits were always good. It's reflecting on that and still being able to do it, I think, and being able to do it safely, I would always say, is, it's an incredible privilege, and love doing it. I think in terms of what it adds to my role now, I think keeping it real in terms of what I was saying, in terms of, whether it's policy, whether it's actually health tech delivery, any of these things, being able to have that insight, but also from working with clients and things, being able to reflect that experience on the ground, but also your clinical network as well. So the people that you work with, all of that, bringing all of that, it's that richness of information, the clarity that you get, all of those different things. And back to, the policy writing, if you don't appreciate that kind of behavior and the mindset that people are working in, and, the last couple of years have been so incredibly tough for everybody on the front line in terms of the NHS, whether it's been COVID, workforce shortages, junior doctor strikes, all of these different things. So being able to like appreciate that and how that impacts everyone that you're working with. And then all of a sudden we're implementing AI in the NHS, which is like a completely like bizarre way to kind of go about it. It's just you know, it's it's tricky. Um like appreciating that kind of context that people are working in. And having said that, I have my frame of context, whereas, if you're a full-time NHS clinician, but if you're working as an inpatient clinician, all of that is very, very different. If you're working as a GP, all of them have different challenges. I have my insight, and I think it's very, very helpful for all the work that I do.
Yeah, that's great. With that in mind, you spend some of your week on being a businesswoman as you wanted to when you were younger. So you did the thing. So congratulations. Tell me about that side of your life.
Oh yeah. So actually, two businesses. So co-founder of a startup called Sima, which I actually run with my sister.
Amazing.
And it's mental health technologies. It's online therapy.
Mm,
And we started this just as I was coming back from the US.
mm.
And my sister, she's a psychologist, so she's actually the subject matter expert. So it was all pre the whole online time. It was very quickly bashed down.
Right.
And it's been a super interesting journey. And I always like laugh about our kind of like early fundraising uh, tries that neither of us, in terms of the whole kind of VC pitches, were
Okay.
very well versed in. So nothing like shame being an excellent teacher.
Absolutely. Absolutely. But I tell you what though, I think getting yourself out there to do the thing and be in the position to feel that based on some feedback, good for you. Good for you. Because the amount of people that will just think about this and have the idea and write the deck, but never actually push for it. Getting the meetings, even doing the work. Like how many people did you have to message or email or cold email to get the intro to the intro to the intro that actually got the meeting? Like if you're starting from zero, like good for you for getting as far as you did, no matter how shameful like those early days were. I mean, it's an incredible achievement.
Was it the best feedback was yeah, word of advice, don't give up your day job, yeah.
Wow, wow, and that
And I
just
was like,
also goes
that's
to
a
show you
great
the
point, and I'm definitely going to take that on
well,
board.
you did action it. You did action that. So
Yeah.
so fair enough. But I don't know.
Um,
I don't know.
Actually, but many years on and through COVID and everything else, we are doing very well and it is
Nice.
grown. But that I would say is a tech-enabled business. We're not
Yeah.
kind of, we run that very well, excellent evidence, excellent outcomes. It's not something that we would probably not kind of have the all AI, all kind of tech
Yeah. Fine.
pleasing startup. So
So
it's a tech-enabled
psychologists,
service.
telemedicine,
Yeah,
solving
yeah,
access, like
yeah.
tech enabled. Yeah, I get it. I get it. Yeah.
And this works well. And then the other startup is Prova Health. We will work on evidence generation for innovation. So it's basically helping to accelerate innovation in healthcare. And this was as a result of work that myself and two co-founders, Gianluca Fontana and Jack Halligan, we all met at Imperial, where I do my policy work. We had started doing some of that work at Imperial. I was looking at more pragmatic ways of being able to generate evidence for tech. And as we all know, it's very, very difficult to sit and do a randomized control trial for any new technologies. So it was thinking of better, faster, but more kind of equally as robust ways of showing evidence for these technologies and how you work on implementation. So it's all types of evidence, economic evidence, and helping to accelerate all of that in the health tech space. And I think this has become even more relevant nowadays, and especially post COVID, where we saw such a massive increase in terms of the number of technologies on the market.
Mm,
So that is the other startup. Um,
great. Well, I'll ask you about Prova actually, because that value proposition has been I would say exactly the same since I very first entered what was healthcare IT at the time, where there were people developing new technologies that were convinced, as the founding team,
Yeah.
would be amazing, but they couldn't get a pilot because they needed evidence. They couldn't get evidence because they needed a pilot. And that chicken and egg
Yeah.
hasn't really been solved other than through relationships. And actually, that was the advice that I used to give people. I can remember when I was at Digital Health London. I mean, goodness knows how long ago that was now. That I found a presentation on my old laptop the other day, and it was literally one of the slides was a chicken and an egg, and one line was trial, the other one was there was evidence, and so it was like to get everything trial, to trial, and like I can remember the only way to break at the time I remember presenting on it. The only way to break this really is to build trust with a human being as a human being, and actually go and spend time with that department, those people, understand them, listen to them, try and get them to trust you, and eventually something's going to give where you're given an inch and you've got to try and take a mile and try and get something done. But then even then defining what the something is or what the something should be became difficult, because then it was, is that what, like a 10-person patient reported thing? Is it a double blind 1,000-person thing? Like, what's the, because ultimately what's going to be enough to then convince someone else to buy it? And it was, and I don't think that has changed. Like, I really don't. But what's your impression of the lie of that land? Has anything changed? And what broadly do you have, sort of big sort of headline advice for people at different stages or doing different things as to how to actually approach that?
I think I completely agree with that. And actually, my master's dissertation that I did was actually looking at it was looking at primary care apps that were
Mm,
on the App Store, and literally none of them had any real
of
evidence or
course, yeah.
medical backing for
Perfect.
them. So
Yeah,
that was like back
perfect.
in
Amazing.
God knows when that was. So then, fast forward a couple of years on doing that work at Imperial, and then fast forward another 5 years on. So we celebrated our 5-year anniversary at Prova a couple of months ago. And, we're still in that space and actually looking at the new LLMs like OpenAI, looking at Claude. It's still that whole space, whereas evidence to show that these LLMs work, that they're being regulated. And it's always that sweet spot, isn't it? It's like obviously regulated health technologies have got a very clear process, but it's everything that falls in between
Yes.
that don't have the evidence. And more than anything, if you're actually an innovator, if you want to be on the market for more than, 6 months before people catch you out and the longevity of your product, you need to be able to make sure that you've got the right evidence for it. And I'd say exactly that. You need those relationships from the get go. And I think that's where that whole it's behavior change, relationships, and influence that you're going to be able to do that pilot. But my advice would be thinking about evidence right from the start, because actually the landscape has changed. That every single person that is going to be involved in your journeys, whether it's your VC, whether it's the payer, the provider, any of those people, whoever you're working with, are going to ask you for that evidence. And you've got to quickly think right at the beginning, you've got to think, who's this evidence actually for? Is it for VC? Is it for the funder? Is this for the payer who's going to, take on this
Okay.
innovation? Is it for a provider? Is it for a healthcare professional? Is it direct to consumer? All those different people. What type of evidence are you going to need? And that's going to vary. What stage is your product at? And again, that will change. So if you're early on in the kind of design of your innovation, it's going to be user feasibility, usability, all those things. Whereas if you're later stage, it's going to be clinical outcomes, it's going to be, safety, it's going to be security, all those different things. And then, once you're actually out in the market, it's the real world evidence and it's the monitoring. But also one of the huge things now, everywhere that you look, cash is king, but also cash is strapped everywhere. So you need to be able to demonstrate economic evidence for your solution as well. Where is the value for money for anything that you're creating? And is it any better than the incumbent? So yes, it might be bright, new, shiny, amazing, but actually is it better than the kind of day to day? Um, and beyond that, it's how are you going back to that behavior change side of things? How are you actually going to implement this innovation? And have you considered that? So it's all of these different things. And it sounds like a huge, like undertaking
Yeah.
at the beginning, but once you start breaking it down into those like blocks as to who, why, what, and when for, then it's much easier to start kind of collecting all the different types of evidence. And you're not going to go straight into a trial. One's going to be, where are you going to pilot it? What kind of early user information do you have? What kind of pilot information do you have? All of these things. And then when you do approach a pilot site, then you've at least got something to present to them,
Yeah.
show what benefits you have.
So do you consider the health economics study? And by the way, I know that can mean multiple things. I'm actually quite interested in what those multiple things are. Actually, like what's the cheapest, quick and dirty health economic study versus what is a really in depth, nice, ready health economic study. But do you consider the health economics as part of your evidence stack? Then is that something that needs to be thought about,
Yeah,
just as
definitely.
early? And if
Yeah.
yes, which it is, so that's a yes. I think then one thing that I know people struggle with is how do I get this done at a reasonable cost, meaningfully, that I can meaningfully communicate a message of cost saving, cost reduction, cost efficiency, whatever. How do I do that meaningfully? But I'm early stage. And so there's that tension. I don't have the money to do a nice, ready, massive health economic study, but what is that first step actually?
That's not what you're expected to produce at the beginning. It's going to be, simple numbers that you're able to confidently present,
Mm,
that will show. And a lot of that is, secondary research based. So it's already numbers and
okay.
figures out that you can base your assumptions on. But in terms of kind of earlier stage startups, what we usually recommend, there's lots of kind of grant funding that's out there to help support some of this, and then working with the health innovation networks as well. So all of these resources are available to people, to definitely get in touch, and then very much help to signpost, advise, and that kind of early stage bit as well. There's lots of resources that innovators are often not fully aware of, the kind of help and support that's out there. But also all the different networks that people belong to. I mean, you and I have probably overlapped in so many different, innovators groups and things, but there's some like amazing people out there, who will always kind of come and help you and advise and all of these different things. But certainly I think that economic evidence, in at this time and point, I think is something that everybody or every single startup needs to be thinking about if they're not already thinking about it.
Um, you mentioned OpenAI, Anthropic, Claude. You mentioned what they're doing at the minute and the lack of evidence around it. We don't even know. We barely know what they're planning at this point. By the way, this is probably going to go out in a few weeks, where the whole world has changed again, and there's probably new stuff come out. But as we record this, OpenAI and Anthropic have released their health versions, and that's kind of what we're talking about here: the ChatGPT Health, the Claude Health. It's really interesting. I'm interested in your take on it, because my feeling on it is that I get what people are saying, that okay, everyone's going to upload all their stuff. I'll go with the OpenAI one because that's one I know better. I haven't looked as much into the Anthropic announcement, but they've said they've said it's not going to diagnose, it's not going to treat, but it's going to help you in your journey. We know that ChatGPT is going to go some way to suggesting potential investigations you should prompt your physician to ask for and all this stuff. So you can definitely get around it. Like it is definitely a clinical decision support tool. I mean, surely, like it just is acting that way. And you can use ChatGPT for it now. It's not as if they're about to release this thing. You can do this now. It's just that they're clearly going to segment part of ChatGPT to be purely for this stuff and hone it in. So I understand people saying, yeah, they're acting as a medical device, but they're not a medical device, and this is not okay. I saw in their report that that they brought out. I even said in my commentary on it in the newsletter, Healthtech Vision, I was like, look at page 13. They've literally just fired shots at the FDA. They've said, we urge you to
Yes.
consider how you're regulating us, or sort of like something along those
Yeah,
lines.
love it.
Like
But
we urge you to sort out your regulatory policy. Like what they're basically saying is this is a freight train that is just bulldozing right through. So either catch up and find a way, or this is just going to be released and you're going to have to do something about it. And we're going to tie this up in court for longer than you can. Like we're already going to be on version 5 by the time this even gets to be judged. So like, that's the sort of vibe that I got from it. And in part, like there is a part of me that looks at their announcement, looks at the video that they put out, where they've got all these case studies of people in the rural US with chronic disease, and they've not got access to available healthcare anywhere near them or anytime soon. And they're using ChatGPT to help them with a flare up of a chronic disease and all this stuff. And it is useful and it contextualizes those. And like the big part of me it is like, I know you're not stopping this because actually it does add loads of value. And I get the concerns and I get the issues and I get it, but I'm playing both sides in my own mind, and I find it very difficult because I evangelize a lot of tech. I'm an optimist. I am also pragmatist and realist, where I'm like, you're not stopping it, so let's just rearrange and reassess what we're doing here based on the fact it's coming. Let's not waste too much energy saying it shouldn't be here, because let's more talk about, okay, how do we now make it as safe as possible? How do we do this? How do we do it? So I don't know. I'm interested because you've got a really good view of this. You're still clinical. You see patients. You are in the regulatory and evidence space as well. And so, what are your thoughts?
let's be honest, the horse is bolted, hasn't it? So, I mean,
Yes.
this is, and who doesn't use it? I mean, I'm the biggest hypochondriac, and I'll put in my symptoms as well.
I'm
And actually,
terrible.
more
Honestly,
more
I'm
from that
terrible.
data privacy side of things, it's something that we touched upon earlier. I mean, if people find something that is useful and they get the utility from something, people don't think twice about entering their data in.
No, not
Like,
at all. Because it also builds trust, because it speaks natural language. So you
yeah.
build a relationship with it.
But it's utility more than anything else. If I'm going to get a 10% discount off X, then I'm going to put in some of my details to get that 10% discount. It's
Yeah.
utility.
Fair deal. Yeah.
But also, if you're going to get help and, that the trusted language, all of that, and it takes you X amount of time to see your doctor, then of course you're going to use it. But actually, this is nothing new. I mean, how often have you Googled your medical symptoms, and actually Google tracks everything that you put in as into a search, and that's how they refine their search settings. So this is nothing new. This is just a kind of a build onto all of that, and that's not regulated. And at the end of the day, what they're saying, it's a recommendation, not here is what we're telling you to do. However, is then, in the NHS, you will be the gatekeeper is the clinician in terms of like what investigations that you will have. You can also go privately, but also again, you will have a clinician. In other jurisdictions, is it somewhat different potentially? Where you can, say, I've read this on on whichever LLM that you've been
Mm.
using, and this is what I want done. Is that the most sensible thing? Is it the safest thing? No. So then it's that kind of, how do you regulate that bit in between? And I think as that evolves as well, because this is, version 1 of
This
what
is
they're
also
doing,
the thing. Yeah.
give it 6 months. What's going to be the
Mm.
next version is upload your CT scan and we'll give you a diagnosis based on that. Or here's a second opinion. This is where we're then moving into very different territory. And it does need the checks and balances and the safety, and it
Yeah.
does.
Okay.
So this is early on, which,
Yes.
building on and based off stuff that already exists, but actually the next step after that, what else can you do? And I think, that shift in the space of, how long have LLMs been out there for,
Yeah.
just over a year, 18 months? And that huge shift in terms of what we're able to do. So I think does
I
anyone
mean,
want that?
that is so interesting, isn't it? What let's sensibly assume that most so so many millions of people are going to use ChatGPT Health and Anthropic Health, Claude Health, whatever they call it. Let's sensibly assume millions of people are going to do that. Millions of people are going to upload all of their medical notes. They're going to upload their scans. Let's assume sensibly they upload all their radiology. What do you think then about the potential for OpenAI to start acquiring Chiron, Cure.ai, like all those, like they'll just start acquiring the algorithms that can actually diagnose? Does it then become a healthcare system of which the front door is the ChatGPT app? Is that literally where we're going, do you think?
I mean, 100%.
Right.
Or why wouldn't they do that? I mean, at the end of the day,
That's literally what's just come to mind for me.
Yeah.
Why wouldn't you do that? Of course.
All of these companies, their actual value proposition, they're tanking billions into it, but actually, how are they making money from it?
Yeah.
It's actually thinking of that, like flipping it round to how are they then going to generate revenue from any of these things? And is it your pocket doctor that, you put in your medical data and it gives you for a monthly fee or whatever else? How are they then going to utilize that? Or how are they going to utilize the data that they are that's been input? Or do they sell that back to X startup or whatever else? Or how does that work? But it's definitely going to be monetized in some way at the end of the day, because they need to actually show that value at the end of the day.
Like, thought experiment. What if this is a good thing? Is there a
Oh,
world where this is a fantastic thing that's incredibly cheap healthcare, that doesn't have long human defined waiting lists?
I mean, it is democratizing healthcare to some extent, in terms of access. If you don't have the deep pockets. We are incredibly lucky.
Low middle income countries, etc.
We have a safety net. If you're in the US where you don't have health insurance and Medicaid and Medicare and everything else is a bit of a disaster right now, then actually you are going to use that. If you are in low middle income countries and access is poor, again, paying for something, if that is the first thing that you've got and actually it's a reason doing, it's obviously not as good as what you can have, but if it's doing a reasonable effort, then should we not be working with these companies to think, how can we make it safer, effective, use it as a first point of contact for people that need it or for anyone that needs it? But it's working with as opposed to actually, let's stop. We need to, it definitely does need checks, balances 100%. But how do you work with them to be able to deliver that better care? As I said, the horse is bolted, so
The
there's no
horse has
point
bolted, yeah, and I completely
you need
agree.
to stop this, and it's just going to get more and more sophisticated, and be able to do more things. But actually, for people who are, we are privileged. For people who are not, um, how does that work?
One of the challenges as well, I think, with it is regulation is at odds with the race that is happening internationally as well. People talk about the US versus China in this, and for the US to clip its own wings by introducing a load of regulatory stuff that slows everything down does not help its cause in winning the race against China as well. And so there's a tension. We talked about on the Pigeon podcast the other day that there seems to be there's probably going to be this tension with, okay, OpenAI is firing shots at the FDA, but you'll know this more than me. I mean, how close is the FDA to government? Is it arm's length? Is it like an NHS England type organization? Is it?
Oh, it's definitely it's closer than the arms.
Right. So it's influenceable.
An organization, yeah.
Right. And so at some point, if the FDA is the blocker to OpenAI doing this thing with health, and we know that China's building it, is there a moment where an administration like the current one, all of a sudden a few people disappear in the FDA, and you're like, where have they gone? But all of a sudden it's all okay. Like I don't know. There's these really interesting, very real. It's been a theme in this conversation. The link between making change and politics. How close is politics to healthcare? And we've been in those meetings as national medical directors fellows. Like, yeah, we've been in those meetings where we've seen how close that is. That will be the equivalent in the US. There'll be surely these conversations.
It's kind of doing it and then doing it properly, isn't it? At the end of the day, they are going to have to be, if you want something to work really effectively,
Yeah,
and people to trust it and to
yeah,
use it. Well, I mean, which one would you use? Oh, here's, the unlicensed version, but actually here's the licensed version that's got the checks, balances, security, safety in it. You're going to go for
mm,
the latter, aren't you?
mm,
I think it's with that building, with that mindset, and whether that, you push that responsibility back to the innovators, uh, or whether it's a kind of, we're going to implement and impose this on you,
yeah,
and it's working out that side of things. But
yeah,
actually, anyone and everyone, you would use the tried and trusted version. Um, and if this is going to be an adjunct to, you know, healthcare, seeing a clinician at some point, you need to make sure that it's something that is your, in effect, your licensed version of something. So I think that's the kind of lens you see it, and not see regulation as a bad thing. Regulation is a good thing when done properly, and when it's not a barrier to innovation. So it's kind of making sure that you're balancing that. And I say this as a, balancing this, and, it can be done very easily, effectively. It's super tricky. And actually, we're dealing with technologies how we don't that we don't know how they're going to evolve and what they're going to be capable of doing in 6 months and 12 months. So that's the tricky bit, is we are, regulating for the unforeseen,
yes.
and at some points, stuff that we don't even understand for all of these black box models, everything else, like, what are we actually regulating?
And black box strategy. So I think this is one of the key points here that I'm glad that we've got to, actually, because this has unlocked a thought of mine. I think because of us both doing that fellowship and knowing the link between policy and politics and media and all the rest of it, I think this has blown this up. So I think one of the big issues here, I started Healthtech Pigeon last week on Sunday. I started it with like beginning like a dystopian film. ChatGPT Health has been released, and it was this very vague, very, very, very vague announcement of, oh, this is what it is, this is what it does, and no chat around exactly what you've just said about, clearly this is the next stage, and this is the next stage, and this is the next stage. There is no transparency. And that gives it the vibe of these dystopian films, which start with, oh, here's this really cool new technology, and ends with everyone's organs being harvested. It's like, what we have is like we have the very first step there, like, but we don't have a national AI strategy or an international AI strategy, or even a, this is what we want healthcare to look like, and therefore this is the beginning, but here's how it plots to that. Like, we don't have that. Like, it just doesn't exist. And that's why this can feel very dystopian, because look at us here just trying to guess as to what is going on. They're obviously going to have loads of radiology. Well, that means they're probably going to acquire some algorithms that are regulated, in which case, well, that means they can start diagnosing. If they can diagnose, then maybe that's going to be good. Maybe that's going to be a bit terrifying. Like, we don't, and we're trying to like figure this out, and it's branching further and further out in terms of like the limits of possibility.
Well, I mean, back to politics. I mean, it's all geopolitics now, isn't it? And it's,
Yes.
the China versus US race, but this is also geopolitics, but also the cross-regulation of AI,
Yeah.
in different countries is just not happening. So
And
even in
that's
the
part of the
EU,
problem.
that's just turning into the most cumbersome, like, it's almost as a good thing the UK's
Slightly outside it,
be
yeah.
able to do it, in their own way, because actually to be able to do that
Yeah.
in a way that's going to be agile and be able to move with the rapid pace of change is
Mm,
going to be tricky.
mm,
At the end of the day, everybody is looking to the FDA, because actually everybody goes to the US with their AI
mm.
stuff. At the end of the day, if you're going to monetize anything, that's where you go, and waiting for the FDA. And what is the UK's role in it? Very different. Are we the ones that kind of say we're safety and, agile regulators, but actually NHS data asset as well to train things on,
Whoa.
data that is much more,
Yes.
it's much better curated. It's from much more homogenous, oh, sorry, not homogenous, heterogeneous population,
Yeah.
and clean curated working that way. So actually is a safety and testing environment, is this where the UK's space is?
Mm.
So looking at it, but yeah, it's going to be interesting.
We definitely do have value if we can just zip all of that into one folder and send it to people.
We're not competitors to the US or China, but actually we've got a very different role to play in this.
Yeah.
And being able to, the health data research service is, a real, this could potentially be the cap and the feather for the UK's AI strategy if done well. Um, but and as a plug, we've written out a blueprint for.
Well, I was gonna say it does kind of lead us on nicely. We've got 10 minutes left, so like just to talk about the report. Obviously, cybersecurity is incredibly important here. So, do you want to talk about what you've written?
Yeah, so this is, I mean, two research areas at Imperial that I work on. So it's the kind of health data work. So we've been working on that for the past, I think, 8 years or so. This is the third in our white papers, and really focused it on basically looking at the UK's or the English NHS's health data strategy. And this white paper is really focused on kind of putting out a blueprint for the health data research services
Mm,
potential strategy and the way to go forward. So, we've been working with a huge range of stakeholders from across the NHS, academia, kind of commercial companies, patients, public practitioners, all of these people bringing it together and putting out a set of recommendations. And then the other bit of work I do is cybersecurity research, which is, again, everyone's seen the number of cyber attacks that have happened in healthcare, but globally in healthcare. And again, a geopolitics tool as well is like, how can you hit a country, hit its healthcare system, in terms of a cyber attack to cause fear and disruption, um, and basically extortion of money.
mm. So, um, it's a blueprint for that. So, yeah, as you said, the Health Data Research Service, which is this new national sort of front door for research access to UK health data. Um, Backed by 600 million, half a billion from the government, 100 million from the Wellcome Trust, aiming to go live this year in 2026. Problem being, obviously, the data setup's very fragmented. Primary care data, huge missing piece for what would be amazing longitudinal insights. And so essentially the core bet here is that if this health data research service is designed as critical national infrastructure rather than like another portal, it's going to unlock this, in inverted commas, triple dividend, which is better care, stronger NHS, and life sciences competitiveness, but only if it earns trust with the transparency, the governance, the visible public benefit, and things like that. How, you know, aiming to go live this year, how this might sound like a really stupid question to ask you, but like, how realistic is it that this happens and that it works?
Oh, I mean, it needs to happen. We can't afford for it not to happen for the
So I would
NHS.
agree. Yeah.
Yeah. And this is like, I mean, the NHS data, I mean, the reason that this needs to happen is that, I mean, we religiously collect data um, across the board, whether it's like primary care, social care, secondary care, every single patient interaction, but not even patient interaction, every single
Mm.
interaction in the
It's
NHS will
unbelievable
generate
data
data.
set.
It's
It's
crazy.
unbelievable. Yeah.
And if we're not using it to its most effective potential, then that's unethical. So why are we collecting the data in the first place?
Agreed.
And if it's going to improve patient outcomes or find the cure for cancer, why are we not using it to its maximal potential? Obviously, safe, ethical, legal, all of those things, secure ways to do it. But we need to be using it. And in terms of what I was saying, we're not in competition with China and the US and everyone else. We have a very different role to play. this is a critical national infrastructure, but also, first and foremost, to be able to improve the health outcomes of people and patients in the NHS. If we're not doing that, then, or that should be the kind of basics, and building up from that, using it as, game changer in terms of delivery of AI and delivery of services, um, and all of like the potential, but also a net income generator for the NHS as well, or for the UK.
Absolutely.
And, that is where we've always been. The UK has always been a front runner in terms of life sciences. We're kind of
Yeah.
losing advantage because it's just not being invested in as heavily enough as it should be. Um, and to be able to get back to the glory days, that's what we need to really focus on.
Yes, agreed. Um, One thing that I just want to pull up on this is that there's like a quite an exciting implementation roadmap, and I don't think that sentence has ever been said by anyone in their entire lives. But I sort of regret saying that. But it it is, in the sense of there's a proposed timeline to 2031
Yeah.
with wins as close as 2026 this year, um, which is to appoint CEO team and board this year, and to launch an MVP this year, which would target 25 research teams, scale it, deploy data sets into primary care and prescribing all this year. That should happen. And then with the longer term plan to fully integrate with Genomics England and trial matching capabilities, that's phase 2, and population scale coverage, including GP prescribing mortality by 2031, that's phase 3. So it feels very real. Like, it feels very much like, hold on a minute, we're going to have incredibly useful revenue generating NHS data capabilities this year.
I think it's not even revenue generating. It's basically, this is what it should be. I mean, and caveat that with, this is our strategy, not the HDRS's
No,
strategy. So
sure,
you might say
sure.
this is absolutely rubbish. So, but they did appoint the chief exec yesterday. It was announced.
Nice.
So actually, the roadmap is working.
Perfect.
Um, but the MVP is there because that MVP is, all of this is achievable because it's not designing something from scratch. This is using existing data capabilities across the NHS. And actually, we've got a wealth of data, expertise, people across the country, the geographical spread, and it's making sure that everything is being utilized to its most effective capabilities, and taking people along with. So actually, that is all, the potential to deliver is absolutely there. And more than anything, I think it's something that's not very NHS, is having that ambition, and having a really strong ambition to be able to deliver this. And, that phase 3 by 2031 is completely achievable. It's, at the end of the day, you need to make sure that you're investing in it. The momentum's there, you're training people
Mm,
up and you're pushing. Because otherwise, if we're kind of, oh, here's another NHS endeavor where
yeah,
we tank a bit of money
yeah,
into and let's see what happens,
yeah,
that push has constantly got to be there.
yeah.
Otherwise, you lose it halfway through that 5-6 year period.
Mm.
Um,
And to comment on a theme that's run through this, that it stays out of politics as well.
yeah, but you need the politics. Actually, I would disagree in terms of the politics needs to be there, because actually, if the current government, the politics isn't championing it as part of critical national infrastructure, also in terms of that kind of
It
the
has to be
funding
cross
side.
party, though. It has to be cross party, because if someone's championing it too much, they'll be like, "Oh, we started it, therefore,
Yeah,
if
yeah.
if they're going to get the credit, we're going to tank it." So,
Right.
yeah,
That's where you're going to
fair
come
enough,
in.
fair
You're
enough.
going to come in and you're going to
Our
spin
point of
it.
agreement would be cross party then. In that
Yeah,
case,
yeah,
a cross party agreement that we're keeping this.
yeah,
That would
yeah.
be nice.
This is a good idea. This is a
Um,
definitely good idea. But honestly, we need this more than anything. We all need this to work. And we're all patients in the public at the end of the day.
Indeed.
I hope it will benefit every single one of us. So,
Absolutely correct.
full support to the team who have the excellent task of delivering now.
Indeed. Sorry, this has been an absolute pleasure. Thank you.
Thank you.
I've learned a great deal. I think you've got a fascinating career. I think you're doing incredibly interesting things. You're involved in so much, and yeah, fair play to you for constructing the career you have done. And I celebrate the fact you are still a clinician and a consultant at that. So congratulations to you, and I hope that inspires people to construct careers that are similar. If people want to get in touch with you and ask you any questions or just to connect, what's the best way for them to do so? I assume
Uh,
LinkedIn.
LinkedIn.
Perfect. We will put that in the show notes. Saira, thank you for joining me. See you soon.
Oh, thank you.